and spend the next hour with you all really diving into maternal mortality, system reform, and research. So we'll just go ahead and get started. Okay, I want to start off this talk today with this statistic. In 2023, it was found that every 2 minutes, a mom was dying due to a cause related to pregnancy. So, a pregnancy-related complication every 2 minutes. And that seems like a really stark time frame to think about. And if we really want to zoom out and really consider what's actually happening behind the statistic, we need to look at both the global context and within that, how the system itself is operating when it comes to maternal health care. So, when we zoom out and look at maternal mortality as a whole, we see that the maternal mortality ratio stands at about 223 per 100,000 live births. And sub-Saharan Africa does account for 70% of these maternal deaths worldwide. But we have seen over the last 2 decades major progress in terms of dropping those numbers of our MMR, and it's fallen by 34% since 2000. But contrasting this particular trajectory is the United States, where our rate in the US has actually doubled in that same period. And this calls for further investigation and also a deeper understanding of what actually is underlying these causes and these reasons. We know that countries with lower rates of maternal mortality have many core features. Among them, they have universal access to maternity care, better integrated postpartum surveillance models, and also more accountability frameworks for respectful care. But that in and of itself does not fully explain what's going on globally and then also in the United States. Now, the United States, as we know, has one of the highest maternal death rates compared to all other well-developed or higher developed and higher income countries. And approximately 1,200 women die from pregnancy-related causes every year in the United States. And if you look at this data here, we also see that this data that women in the U.S. are also affected by race and other social factors that are influencing their overall maternal mortality rate. And so Black women in the US are most at risk for maternal mortality with a 3 times greater rate than their white counterparts. So not only is there a problem of maternal mortality and an overall death rate that is concerning in the United States, but we have a huge issue of racial disparity and inequity that is deeply embedded into the system. So, what is maternal mortality? And I'm a big fan of really diving into definitions because I think that it tells us a lot about how we are collecting data and what we are doing with that data. And so, if we think about maternal mortality, we have a lot of definitions out there in the ether. And a global definition that's most commonly used, which is defined by the World Health Organization, is death of a woman while pregnant or within 42 days of termination of a pregnancy, and for any cause related to or aggravated by the pregnancy or its management. And what's interesting here is, we really focus on this very specific time period of during pregnancy or within 42 days after. Now, the US defines maternal mortality a little bit differently. The CDC actually includes the entire 1 year after the end of pregnancy to be a part of pregnancy-related deaths. And so it captures a bit more nuance. We're able to capture any chronic conditions or complications that might arise in that postpartum period, which is interesting considering the fact that the US as a whole does not necessarily have a very robust postpartum healthcare structure. But regardless, we do consider this data when we're talking about maternal mortality in the US. So, what are the implications of these definitions? Because they're different and because they, continue to vary if we think about different jurisdictions, countries, states, cultures, etc., we have to understand that this complicates data collection and it also complicates solution building because we need to say and we need to build solutions very specifically for a very specific system since we know that no two systems are counting data the same way. And what this results in is quite a few phenomenons. We have undercounting and overcounting. So in low resource settings where there's maybe less infrastructure for maternal mortality review committees or other, oversight committees that are looking at the data, we have underreporting happening a lot. In high resource settings, we have this definitional variation. And so as a result, we might be misclassifying certain cases as counting in this bucket of maternal mortality or not. And of course, as a result, as evidenced by our racial disparities in maternal health care, this misclassification ultimately usually impacts the most marginalized groups, the ones who are most vulnerable. And so we have fractured data, which means we have fractured solutions in place. And so as a result, the system is inadequate and insufficient to handle what is actually going on. Now, maternal deaths themselves is actually a largely preventable problem. 80% of maternal deaths are preventable. 17% of these deaths occur within the first 24 hours of birth, and 60% occur within 6 weeks postpartum. And we clinically understand a lot of what goes on when it comes to maternal deaths. We know that root causes include hemorrhage, preeclampsia, any sort of cardiovascular condition or complication, infection, and also late presentation for care all contribute to maternal deaths. And this is widely understood and acknowledged within the field of obstetrics and gynecology. So that's not the problem here at all. But if we just look at clinical root causes, we miss a large part of the problem. So it's important to really think about how public discourse, both in the public health world, the advocacy policy world, and then in the clinical medicine world, has looked at maternal mortality as strictly a clinical outcome. But we need to consider that it's also part of this much larger story. If we only look at proximate causes of maternal mortality, we are missing all of the antecedent causes that lead to it. And it is this, you know, interplay of multiple components at once that we really need to consider when we want to build actual solutions. So this diagram is an attempt to sort of capture this nuance with the trees, the leaves being preventable maternal deaths as a whole, right? That 80% no. And the root of this problem, of course, is the fact that there are systemic failures in maternity care, and that's the trunk. But then as we get into the root specifically, we see these other components that are not necessarily those clinical outcomes, but instead things like delayed diagnosis and treatment, poor patient-provider communication, provider stress, workload, and burnout, structural racism and bias, and this idea of cascade iatrogenesis, which I'm really going to dive into a little bit more, but it's an attempt to really characterize how one thing leads to the next, leads to the next. So iatrogenesis comes from the Greek word iatros, which means physician or healer, and genesis, which means generation or birth. And this concept of something that is brought forth by healer. And in the case of, medical care and the healthcare system in general, it's this idea that, ill health or disease can result from the use of certain interventions or from medical care writ large, specifically things like diagnostic testing, treatment, or hospitalization. And so it really attempts to capture the potential downsides that occur as a result of a highly medicalized, highly efficient healthcare system. And so, if we're going to then look into what cascade iatrogenesis means, it's the chain of medical interventions that lead to harm. And this harm can be unintended entirely. But when we look at maternal mortality and we're looking at the data, we are ultimately only looking at that last point, right? So, how do we work our way backwards? And how do we actually really look and examine the chain that leads to this? And so, obstetric violence or mistreatment in maternity care, also called disrespect and abuse, there's multiple names for it, is an attempt to really characterize all of these components that contribute to harm in maternity care. And so, it involves verbal and physical abuse, coercion, denial of care, and mistreatment. In obstetric violence, specifically, the term is actually rooted in a lot of really interesting history and even controversy. It was actually birthed out of Venezuela in 2007 as a result of a lot of outrage and outcry over a lot of maternal deaths that were happening in the area. And so it was first codified in law in Latin America. And then from there, it actually grew and sort of transcended into various spaces, including, policy and advocacy, and then eventually public health and clinical medicine. And we know in the United States, 1 in 5 women report experiencing mistreatment during their labor and delivery experience. So that is a significant number to also contend with. It's not just about receiving care for XYZ symptoms and then leaving the hospital, but no, there is this entire psychosocial component of care that is being not properly doled out, and women are experiencing this and reporting back. And it reflects in how our maternal mortality crisis continues to prevail. Now, this diagram is an attempt to really characterize what kind of falls under the umbrella of obstetric violence. And what I really like about this, visual is that it shows this spectrum from normalization to degradation to assault. And it's this idea that just like a cascade exists and one thing leads to the next, leads to the next, these actions and these moments in care are not black and white. It is not just, one thing happens and then another thing happens as a result and that is it, but it is the accumulation of a lot of different actions. And so you see kind of at the bottom of this triangle, these normalization components of care, things like, hostility towards certain clinical care members or jokes about birth plans and, this idea of how we, pathologize pregnancy and birth in some ways that can be diminishing to what a pregnant person wants and hopes for. And so again, these things then escalate and go further and further up this diagram to, the more extreme versions of violence and harm and mistreatment. So what can we do? Well, first, we have to stop looking at just the endpoints of care, right? It's not as simple as you walk into the hospital and then you leave with a baby and then that is it. But instead, it is the moment to moment interactions that actually shape labor and delivery. And if we really break down labor and delivery as a, aspect of medical care, the the vacuum in which L&D and intrapartum care exists is really unique because it's where technology, protocol, and perception all intertwine. And it's also a moment of extreme heightened emotional arousal. It is you're managing two patients at once, and it's often very urgent and very there are many factors that go into how a birth can happen. And also, for that matter, it's the one area of medicine where you have a patient walking into the room with expectations of what they want. And that changes things because you are now thinking about not just the medical system or looking at XYZ symptoms and interacting in a certain way with it via an intervention, but actually like the social and communicative component of two people interacting in this medical encounter. So, how can we actually disrupt systemic inertia? How can we stop enabling disrespect and abuse in childbirth? That is the fundamental question that I want us to grapple with today. And it's really in line with the theme and the title of this talk of what cannot be seen cannot be changed, right? So right now we're wrestling with what do we know and what do we not know about maternal mortality and maternal health as a whole, and what can we do to actually change it? So I could, alongside my team at Massachusetts General Hospital, we conducted a mixed method study that looked specifically at medical providers and their perspectives around disrespect and abuse in maternity care. And this was one of the first studies of its kind to look specifically at physicians, midwives, and nurses. So we were capturing a wide school of thought when it came to obstetric care, and also one based in North America or in the United States, since a lot of the work that's in this field up until this point has been primarily in the global south, has looked at only patient perspectives, or has only looked at midwives or just nurses, and hasn't attempted to actually cultivate all of this data in one place. And then the mixed methods approach is also enables us to look at both the quantitative and qualitative side of this problem. So we had three main hypotheses that we wanted to wrestle with: knowledge, stress, and care quality. And, if you think about the healthcare system, those are all aspects that make a lot of sense as to why we'd be really interested in what's going on. When it comes to knowledge, we were curious to know if providers were more likely to acknowledge that obstetric violence and disrespect and abuse existed in obstetrics in general, as opposed to at their own institution. And this was really, coming from the literature itself, where there's been so much controversy and pushback at the term of obstetric violence, a lot of providers feeling it's inherently antagonistic or it's not necessarily conducive to any change, while others feel like, oh no, it's actually really reflecting a true state of affairs when it comes to gender-based violence, whether that be intentional or unintentional. So there's that debate there that we wanted to really see and wrestle with. When it came to stress, we were curious to know if higher perceived stress would be linked to lower care quality, which, seems intuitive if we think about it, but is that something that is driven by factors like staff exhaustion and patient acuity, especially considering the nature of obstetrics being so intense. And then, of course, care quality. Do communication and autonomy, these attributes of respectful maternity care, do they actually predict how care quality is achieved and doled out? So, to start off with, we looked at the comparison in belief in obstetric violence existing, and there was a statistically significant difference in providers who believed that it existed in obstetrics and midwifery writ large in the field, as opposed to those who believed it existed at their hospital. And this, really points to a very common, psychological phenomenon of fundamental attribution error, and we're very likely to want to look outwards when we're looking at a problem as opposed to acknowledging that it could be within our system and within our space. And of course, again, it points to this controversy in general in the field when it comes to using these terms and discussing this in the context of maternal care. Now, when we looked at the perceived stress, which was a self-reported, measure that we evaluated, we looked at that in the context of care quality. And now this data didn't necessarily give us a statistically significant outcome, but it does point to further investigation being needed, specifically to look at care quality as it applies in obstetrics specifically, and if there's specific stressors that should be more evaluated than a generic PSS4 scale, which is a validated measure for stress, but maybe not might not be as applicable to the specific stressors in obstetrics and in labor and delivery as a whole. And then we also conducted an exploratory factor analysis. And so this is a statistical technique that essentially attempts to sort of find a way to parse through data and specifically bucket more latent factors that contribute to certain trends and certain answers. And so in this case, we had a lot of survey questions regarding respectful maternity care, care quality, index scores, etc. So using those, survey questions, what are the variables that, play a role in how they're categorized? So are there questions asking about clarity and informed consent, or are they about safety and dignity and respect in that way? Is it about, a woman feeling empowered in her decision making? So again, communication, respect, and autonomy were seen to be the three significant latent factors extracted from our data, of which communication was the largest contributor to all variation that we saw in care quality answers. So moving on to the qualitative themes of this research, there was four major themes that were really, pivotal to what we were, conversing. And again, MGH as a hospital in Boston is a academic medical center, sees about 3,800 births a year, is an extremely busy maternity care center. So there's a lot of factors that go into that environment specifically. And we saw that when it came to patient-provider communication, which was again one of those root causes in that tree diagram, informed consent is one of the first things that breaks down in obstetrics, and specifically when it's an obstetric emergency. And we had nurses, physicians, midwives all commenting on this fact that, you do the best you can. You want to debrief with the patient, you want to answer their questions, but you're also managing two patients at once. And there is so much clinical discretion and urgency that goes on, urgency that's required to do this work, so that there's that balance there. But then as a result, informed consent sometimes is pushed to the wayside, or it's, minimized or done in a less cohesive way. And then, of course, you have this idea of within communication, there's this component of perception, right? In a medical encounter, you have a provider, you have a patient, and the provider is technically the expert in the room, and they have, the knowledge to make these decisions for the greater good, in which in this case is making sure that mom and baby are both safe and healthy. But of course, in painting those pictures, in communicating those reasons, those risks, it's possible and very likely that a lot of patients feel like they're being threatened, they're being coerced, they're not feeling like they're being listened to or actually engaged in the process at all. Then we pivoted to organizational factors being another major qualitative theme. And this, of course, makes a lot of sense when you think about how much healthcare has evolved under a highly medicalized system, especially in the United States. We're seeing this sort of, phenomenon of McDonaldization of healthcare, where we're really emphasizing efficiency and bureaucracy and making sure that we're getting patients in and out and triaged right away. And so as a result, birth and labor become a checklist, and there's just so much volume and so much busyness that there's not enough time to necessarily sit with each patient and walk them through everything. But regardless of that being a true, feature of the healthcare system, it doesn't necessarily mean that there should be any violations of privacy and dignity and safety. So it's that balance there of, okay, where do we strike that healthy balance? Language discordance kind of within this communication component was actually a really important part. We saw MGH sees a lot of patients who are Spanish speaking, Haitian Creole speaking, as well as a plethora of other languages. And language concordant care, which we know is a really big indicator of better outcomes. The minute you have discordant care, you have greater, longer hospitalization stays, more readmissions to the ED, more complications, more dissatisfaction and psychosocial, adverse outcomes. And so we know that language discordance is a really important component of care. And when we looked at this data, we saw from both the physician perspective and the midwife perspective of how, when you're thinking about obstetrics, you're thinking about intervening immediately, you are, running out of time and you want to communicate the risks, communicate what you're trying to do as an intervention. Finding an interpreter or finding a tablet that will interpret for you is not always the major priority. But as a result of that, then it's often these patients that do not speak English as their first language that are not told what's really going on, or are told what's going on in a very limited, minimizing way, and in doing so experience an immense loss of control because their decisions are essentially being made for them, even if informed consent and communication is the ultimate goal. Now, if we were to look at the other two themes, patterns and disrespect was a big one, mostly in relation to this idea of compliance, right? Again, I bring up this point about the expert in the room because it really speaks a lot to the medical system and the dynamic that exists in a medical encounter. And, you have expertness, which is very functional because you need your provider to know what they're doing. But you also cannot minimize the fact that the patient also knows what's going on with their body and their experience. And so that conflict can sometimes arise in the name of compliance, where providers, excuse me, sometimes feel like, the patient is not going along with what you're presenting and they're putting up a fight, which again was well within their right, but then that sort of hinders what could be a more smooth approach to medical care. So it's how do you balance that sort of communication breakdown? And then, of course, you have cultural, racial, social biases that really alter how care is being provided. Within our data set, we had many providers comment on maternal age, substance use history, race and ethnicity, being some of the big factors that sort of changed how they approach their care and are variables that they believe are actual like bias factors. And then when it comes to clinician knowledge and belief, again, kind of with that first graph that I showed you, disrespect and care, disrespect and abuse exists. And that's something that's, physicians and midwives and nurses are able to acknowledge, but it's again harder to articulate exactly what that means in the context of their work at their hospital, in their labor and delivery unit. So the key qualitative takeaways, and kind of in tandem with the quantitative, data that I shared, is that workload, facility infrastructure, these are all major constraints in the provision of clinical care, and that's the case in any setting. Low resource, high resource, it's a problem across the world. But we know that, when we remove this question of resources, which has been a big part of this research in global health, because since so much of this research has come out of the global south, a big, explanation that they've used in a lot of literature is, of course, resource demands is not meeting what they need to meet. So then these things are happening. When we take the resource question out of it by looking at a high resource, medical academic medical center, we're seeing then that it's not just the resources that is leading to these outcomes, but it's consent processes and communication procedures that are genuinely breaking down, which means that those are also the areas of medical care that can be leveraged to prevent disrespectful maternity care. So, pivoting to solutions, right? How do we actually build solutions now that we've considered what maternal mortality is defined as, what's going on in the world, what's going on in the United States, and then what's also happening when it comes to mistreatment, disrespect, and abuse? What is actually sustainable and what is actually meaningful when it comes to building solutions? Well, first, I want to just take a second and really acknowledge the fact that development without safety is objectively a moral paradox. And here's what I mean by this. We have used, human geographers, economists, scientists, the whole gamut of, academics out there have used developmental markers as a way to indicate progress, right? We have the demographic transition model that takes us from stage one to stage two to stage three. And a big part of those stages is, ensuring that individuals who are in that stage have a healthier, safer life. And for countries that like the United States and other high income developed countries that are considered stage five, we think that progress is linear. We're assuming that we are achieving XYZ amounts of safety, but the fact of the matter is we are not. And we are seeing this in the data here. We have a robust healthcare system, but women are still dying of childbirth and pregnancy related complications constantly. And we don't have enough oversight or infrastructure to even begin to mitigate this as a result, which is why we've been seeing, rising rates in maternal mortality over the last 2 decades in the US. So that's what really, takes us to this idea that we are operating within a stable but suboptimal system. So currently, we're in sort of what I would call a bad equilibrium, where we have this huge focus on self-protection, which makes sense because, we're talking about fast-paced care, defensive medicine practices, which is a big part of obstetrics because of, litigation rates. And of course, but we also have on the flip side worsening outcomes for women through disrespect, abuse, and systemic bias. So it's this balance here where we're sure we might be stable, but it's not necessarily a good equilibrium that we're at. It's objectively suboptimal. And so what that tells us is that we are essentially stuck. We're stuck in this moment of systemic inertia where we do not know where to go from here, and we're stuck in terms of what we can do next. And we know that these negative outcomes continue to exist. The data is there. It shows us that this racial disparity exists in maternal mortality, that Black and Hispanic women are dying at a 3 times greater rate. We have these numbers, but the system remains stagnant, right? There's been very little change in care practices and accountability. So what does that really mean? I introduced the topic and the concept of cascade iatrogenesis earlier to really show sort of this domino effect, right? One thing can lead to the next, which can lead to the next. And when you think about that, that's a, fundamental feature of medical care, especially in a modern medical system. But then think about this slanted table, right? These dominoes are going to continue to fall, but this slanted table is going to make it so impossible to ever stabilize. And that slanted table is how maternal health care is currently being operated. And the people that are going to face the greatest harms as a result of this system are the ones that are the most marginalized and are the most vulnerable and at risk. So let's break this pattern. That is the big goal of today's talk, of my work, of what I hope a lot of people's work is in terms of, maternal health care and the US healthcare system, the global healthcare system in general, is how do we actually break this pattern? Because we can spend all day talking about numbers, trends, statistics, data from research, but if we don't actually take that into policy and advocacy and actual system reform, then we're not doing anything with it. So, the World Health Organization has a few guidelines for what they define to be respectful maternity care, right? Which is the exact opposite of what I've just spent talking about in terms of disrespect and obstetric violence is the goal. It's what we want to achieve. And this means that care is free from harm and mistreatment. It maintains privacy, confidentiality, and dignity. It ensures that informed choice and support is always given, and we have equitable, non-discriminatory treatment. And as you can see with the data I presented today and also the general state of affairs, we are not necessarily meeting many of these, tenets at all, actually. We have, an extremely high rate of harm and mistreatment and informed choices being broken down, and we already know that equity is a big issue. So how do we actually come back to these core components and how do we achieve them in a system that is continuously changing but also staying the same? Well, our study did confirm that providers recognize that disrespect and abuse is real. And that's a really big first step, right? What cannot be seen cannot be changed. If we are unable to articulate a problem, then how are we going to actually build solutions for it? So that in of itself is a fantastic first step, but there's also these constraining factors: stress, hierarchy, and fear of blame, right? So just recognizing the problem is not going to do enough for us. So that means we really need to think about multi-level solutions. Solutions should not be siloed in one aspect of care or in one type of solution, but instead needs to be far-reaching. So from a systems level perspective, we could implement real-time tracking and transparency tools, right? Building these more dynamic and holistic dashboards that show disrespect and abuse complaints, that integrate birth plans directly into someone's EMR, that looks at, informed consent across the entire, a duration of pregnancy as opposed to just in this moment of labor and delivery, whatever that might be, implementing that broadly across the system. From a culture and training perspective, of course, we can do more work in terms of really identifying and examining implicit bias and how consent dynamics really change when implicit bias plays a role and what that really looks like in terms of care provision. When it comes to accountability, we can look at licensure renewal and accreditation and tie that to, goals to reduce mistreatment. And we can examine this data by subgroup status. And of course, patient empowerment, right? At the core of all of this is, wanting to ensure that we are truly having patient-centered shared decision-making processes. So can we implement digital feedback tools? Can we look at patient advisory councils at hospitals and look at provider perspective from a variety of cultural contexts, learn from one another, actually build out this, patient kind of involvement component. Ultimately, when it comes down to is we can't have any more hiding, right? We can't improve what we don't measure. And right now, the crisis of maternal health can, there can be attempts to distill it into something as simple as the rates are rising and it's worsening in the United States. But if we don't actually look at all the small components that lead up to it, we're going to get nowhere. And, this can start with something as simple as standardizing definitions, right? I talked a little bit earlier about what, this differential definition, conundrum does in terms of data collection. So can we adopt unified metrics? Can we actually align these definitions globally and then locally and really have that improve how we conduct, maternal mortality review? In terms of data linkage, right? Can we do a better job of capturing a true sequence of events, right? We know that care is not isolated and it's not a single moment that causes other outcomes. It's everything that contributes to your care, right? Your entire, life, your social factors and variables that play a role. Did you have access to prenatal care? All of these components play a role in how you're categorized as low risk, intermediate risk, or high risk during pregnancy. So can we integrate and have a more linked data system in place in hospitals? Can we look at maternal mortality review committees to look at not just deaths through the lens of clinical complications, but through system contributed deaths, right? This idea of iatrogenesis. Can we actually expand this review? And right now, we're at a really interesting crossroads in the country in terms of what is actually happening to maternal mortality review committees, with many getting defunded or, stripped down. So we're in this, really interesting juncture where we need them to be an accountability measure, an arm for oversight, and yet we're still not, making it happen in the places that need it the most. We could also implement quality dashboards and really look at, these respectful maternity care indicators, right? Those care quality, scores that I used in the data, can we actually use that widely across hospital systems as an actual metric to achieve beyond just the rates of C-section, the rates of, hemorrhage and sepsis and complications, right? Can we use these tenets to actually serve as a metric to achieve. And of course, we have, policy in place. The Shine for Autumn Act is an example recently introduced or reintroduced in Congress in regarding, standardized reporting, right? Having more oversight in terms of what's going on in labor and delivery to lead to stillbirth. So can we support policy and advocacy in that realm as well and push that forward to do so in a way that's sustainable and effective? Ultimately, to stop the cascade, we must call for a major paradigm shift, right? If we look at healthcare the way it is, if we continue on in this path, we're going to just stay in this systemic inertia. The system is going to operate and exist the way it exists currently. And hospitals and all other delivery care models must move from this reflex of intervention first to reflection first. And that, might sound a little lofty when we're thinking about, the demands of obstetric emergencies and labor and delivery and what needs to happen clinically in that moment. But as a culture, and as a care model overall, if we have this shift overall, it will reflect even in those moments of high intensity and emergency. And ultimately, we can start doing this by empowering providers and stakeholders, having them be at the forefront of fostering change, and ensuring that we're creating these frameworks for accountability and respectful care, right? We're not just looking at this as a list of goals that we want to achieve in some distant future, but instead say, okay, these are the metrics that we want to really evaluate, and we want to make sure that the work that we're doing and the interventions that we're doing in place, in practice, actually reflect these goals. So really integrating that system fully into all aspects of maternal health care, and not just labor and delivery, but throughout prenatal and then all the way through postpartum, that 1 year, after you give birth. And ultimately, the goal for all of this is a better system, right? That maternal healthcare system that actually prioritizes safety and dignity and trust, because that's what will actually lead to better outcomes. And that's what's sorely missing and lacking at this current moment. And yes, there's so many contributing factors to our worsening maternal mortality rates and, questions of access and insurance and all of these other logistical problems that are obviously contributing to this issue. But at the core of all of this is the treatment of one another within the healthcare system, how that communication works, how that informed consent works, and what's actually going on in the provision of actual medical care, not just medical care as a concept. So I want to kind of finish off this talk with a quote that I really, feel very strongly about. Women are not dying because of diseases we cannot treat. They are dying because societies have yet to make the decision that their lives are worth saving. And it's this idea that we cannot keep justifying pregnancy, childbirth, and all such complications as this natural phenomenon that occurs for women or for individuals who are giving birth and becoming pregnant, but instead it is what is happening in the maternal mortality that we're seeing, the complications that we are seeing are symptoms of a much larger and much more fragmented and broken system. So with that, I will, open it up for questions. I'm happy to go back to any slides if there's anything to clarify, but thank you so much for having me this evening, or this afternoon if you're on the East Coast.
Um, Sahana, thank you so much for this wonderful, beautiful talk. We've invited folks to add in some questions into the Q&A section, and I know some folks have put some questions in the chat. So first off, someone asked if there were existing data specific to states, race, and economic status in terms of some of the things you were discussing.
Absolutely, yes. Especially with the United States, there's been a lot of data and, analysis that's been done across US Census Tract data. So looking at race, social deprivation, there's a lot of different indexes that we're able to use to really define what's going on. So there is data out there and, we have maternal mortality rates that are split by state, right? We're able to identify which states are the worst in the country and how that ranks up all the way to, first place and then 50th. And we also have data on where we have the most social deprivation when it comes to maternal care. And specifically, especially, we also know what regions and counties are the most lacking in terms of resources. So about 33% of counties in the US are identified as maternity care deserts. So again, when we look at that data specifically, we're really able to dive into socioeconomic status, race, all of the variables that, I mentioned earlier.
And then someone else was asking, would you be able to make any of these information you shared, is particularly like your presentation or other handouts available to participants today?
Yeah, absolutely. I'd be happy to share a copy of these slides. I also can link two of the journal, publications that we have from the study itself to really, if you would like to dive deeper into what I was trying to, succinctly summarize for us today. So I'm happy to share all of that with everybody.
It's wonderful. It's wonderful. And if folks wanted to get more involved in some of the work that you were discussing, like what advice would you give those who were on the call today?
I think that the really important part about a topic like this is that it is so multifaceted and like really plays a role in a lot of different industries and components. It's not just like the clinical medicine enterprise or the research enterprise, but it is policy, it's advocacy, it's community work, in the on the ground, right? Talking to people, informing them of their choice, like community centered, practices, doulas, like there's so many ways in which someone can get involved in this type of work that, I don't think we need to look at maternal health care or reproductive health care writ large as something that you have to have like medical expertise to engage in, but you can actually just engage from a policy perspective, even supporting bills of, importance or stopping, defunding of like maternal mortality review committees or whatever might be going on, right? Those are things that you can do within your community.
Yes, yes. Oh, and uh, one of our attendees, Amitha Lewis Jack, she was asking, can this if this data can be linked to their malpractice insurance and have them pay higher rates?
Oh, that could be a way, like a potential accountability measure for sure if we were to look at specific, reports. The biggest problem with that specific potential solution is that there's very little reporting or data collection on the ground in terms of who is experiencing the mistreatment in what cases. There's very little reporting like mechanisms that exist in a lot of these hospitals for that to even be like collected somewhere. Now, if we could collect that data and really say, okay, I had XYZ experiences as a patient in this hospital. This is what I really came out of it from. And you linked that to overarching, care outcomes for a given practice, you would maybe be able to make that link and actually do something there. But given the fact that obstetrics and gynecology is already, has an extremely high rate of malpractice suits and lots of litigation, the field is already oriented towards a very defensive medicine practice. So I don't necessarily know that that would actually be a very sustainable or effective solution. And I think if anything, we would probably alienate providers from wanting to be accountable and actually, engage in this reporting system.
Yes, yes. I want to hand this off quickly to my colleague. I see your hand is raised.
Yeah, absolutely. I know there are a number of great questions in the
Yes.
chat. So excellent conversation, Sahana. I know we definitely have at least one maternal mortality conversation at BCPH on a yearly basis. But especially to your point about alienating providers, I think, one of the biggest issues with it could be obstetric violence or it could be anything related to physicians as well, is we can have these fantastic dashboards that you're talking about. But how do we really have the systems change? Because even if we have a fancy dashboard, that doesn't change the work hours and the other things that are incentivizing people not to spend time with their patients, and for a lot of these outcomes to happen. But what are your thoughts on that?
I think that's actually it's a really important question because I think it's at the crux of this work is, okay, what can we do that's even effective and sustainable? And then what about the natural components of medical care, right? That we really just can't erase. We're not going to magically have, an overstaffed unit all of a sudden with a bunch of beds and, an hour with a time of time to spend with each patient. But I think and I've been having a lot of these conversations recently about this very specific issue. And I think the biggest part is, you can accept that there is some level of, basic functionality when it comes to how the medical system operates, right? You're entering a hospital, you are hoping for care in some sort of, triaged, like tiered system, and you want to experience XYZ interventions. And that's a big goal and an overarching, benefit of having medicalized care in this way. So if we're able to just, isolate whatever exists in that little umbrella of like, okay, these are things that are just naturally a part of the system, and we actually can create solutions for the parts that we can change, like how we communicate. Can we, implement a more robust informed consent process that spans the entirety of pregnancy, right? Where you're able to communicate with your provider, ask questions, really engage with your actual, potential risk as a patient, so much so that you're not, being thrown this information for the first time and hearing it for the first time, in labor. Is that something that would then ease the thing of how obviously you're not going to have 30 minutes with the patient if something's going wrong and you need to intervene. If you're wheeling a patient off for an emergency C-section, you're not going to have 30 or 40 minutes to discuss every single thing under the sun, right? And that's just a natural part of medical care. So it's like, okay, that's okay. Let's work our way backwards and actually really dissect then each moment and each chain in that reaction.
Absolutely lovely. I do have additional question as well. You had a slide that was related to implicit bias training, and I'm somewhat of a critic of this just because there is a lot of recent research that says that implicit bias training is not effective, or in fact has paradoxical
Mhm.
results in making people, unfortunately, more racist or more sexist or whatever the case may be. And one of the things I didn't notice in terms of being able to have more providers that look like the people that we want to serve, right? So more African American providers, Latinx providers, et cetera. So thoughts on that as well.
No, absolutely. I think the same point that was made about language discordance and concordance is actually the same point that can be made then about having a provider who looks like you and has similar identities to like really, understand that life experience. And there's an interesting kind of body of literature about narrative humility in
Mhm.
medicine and this idea that, okay, like as a provider in this interaction, you have to understand that you're never going to know every single thing about this person, right? You can make certain assumptions and decisions based off of, you know, test data and diagnostics and do those things within the realm of clinical medicine, but you fundamentally are not going to know an entire person's life story. So what can we do to bridge that gap? It would be, diversifying the workforce, right? Ensuring that we have providers with a variety of life experiences that are going into these fields. And that I think is something that we have to then step back and really think about how we revolutionize the medical education system to reflect this, right? I think right now the medical education system is pushing, certain types of people to certain specialties more than others. And so you're seeing this kind of funneling approach with how we have education. And then we also know that in the US, like we're one of the only countries where we have a decrease in empathy between medical students in their first year and then their fourth year, right? So something that we're doing there educationally is not building or is not sufficient for what we want in terms of a diverse workforce to reflect a diverse population. So I think, and it's a roundabout answer to your question, but I really do think that that to answer that, I think we'd have to back up all the way to medical education, how we're training future physicians, nurses, midwives, doulas, all of the health professionals in this field.
Yeah, thank you so much. Yeah, I know other people have questions, but thank you for answering mine.
Um, so Sahana, there's two questions from one of our participants, Kamaldeen Sunny. Um, they thank you for the excellent presentation and wanted to know, do you have for states in the US with a view, do you know about the effect of Obamacare denial in some states on the issues you were discussing today? I guess that's, I think might be in reference to a lack of, Medicaid expansion and how that might impact. Um, And then they also were asking, would you consider those attacking obstetric clinics as pro-life protesters as part of this violence?
Well, to answer the first question about Obamacare denial, insurance access, there's definitely a lot of robust data out there in terms of what that impact has had on maternity care. And specifically, if you look at states with less expansive policies, right, compared to those with more expansive policies, you can see a huge differential there in terms of maternal outcomes. And when there was that one, and I'm blanking on the specific date when this happened, but when Medicaid did expand into the postpartum period a little bit more than it was originally, we saw, a really great benefit in terms of like having that access to care because we know in the US we have almost no postpartum healthcare enterprise at all. And so expanding access in that regard actually really did assist with, improving outcomes. But again, that wasn't necessarily universally implemented or implemented at the same level in every state and every county. And so I think for that data specifically, it's definitely worth looking into more as to how denial and certain types of access restrictions play a role in these outcomes.
Thank you for that clarification. Um, and I guess also someone was asking, Buffy Jameson, Faye was asking about where I can find the new literature on implicit bias. And I know you mentioned you were willing to link some articles you had authored. And I didn't know if you had any authors you wanted to recommend on this or training manuals, training materials.
I mean, I think
And I
Dr.
see,
Carpenter
yeah. Oh, fabulous. Yeah.
is putting in some great resources on implicit bias, so I would definitely look at those. I think I'm more familiar with it in the realm of accountability and, excuse me, how it applies to, maternal health care. But I'm actually very excited to look at these sources and learn a little bit more about it.
Fabulous, fabulous. And also for those who might be coming in from academically aligned fields, if you do like a Google search on these search terms in Google Scholar, if you go to PubMed um, .com, you can find resources as well, or just do an overarching Google search. Things are bound to pop up that might lead you to some trustworthy resources. And obviously, there's some links in the chat here that will take you automatically right to things that you need. Um, I do see that someone has raised their hand. Let me go over to there. Um, Kamadine, I'm going to put you on allow to talk and you can ask your question live. And if anyone else would like to ask their question live, please raise your hand. So Kamaldeen, you're able to talk if you
Yes,
want to come off mute.
good afternoon.
Good afternoon.
Hi, good
Good.
afternoon.
Thank you again for the presentation. But my concern is this, because the data reflected high incidence of this in African American, right? But the source of the data, if I'm African American, I have Blue Cross Blue Shield insurance.
Mhm.
Chances are that you're not likely going to get anything about me in your data. Most of these public hospitals, county hospitals that depend on Medicaid would have mostly African American, right, and Latinos. How did you in any way account for this in your data analysis? Thank you.
If I'm understanding your question correctly in regards to insurance status and what this data typically captures at a specific hospital, I mean, a lot of these hospitals really are seeing a wide variety of patients, right? You have safety net hospitals like BMC in Boston, Boston Medical Center, that obviously is seeing a much larger Medicaid population than they might be seeing private insurance. But at an institution like MGH and a lot of other academic medical centers, you are really seeing this wide array of insurance status or lack thereof. And so, really, in terms of capturing, like you said, those intersections, right? I think it really would really come down to what study site you're working with or what population you're looking at. And of course, this changes drastically with the US specifically state by state and county by county. So we have, almost no uniformity when we're thinking about this, right? This study that I conducted with my team at MGH was focused specifically at MGH, so it's taking into consideration a very specific context. But even if we were to zoom out to rural Massachusetts, we would probably have completely different, answers and, expectations from providers about what maternal care looks like. So I think that the data does exist there for sure, but it's just a matter of how are you finding it and defining it.
Thank you so much, Kamadeen. And just looking to see, I don't see any additional questions. I did want to share that Linda Arnade very kindly shared a link to her group in Pittsburgh that works on aligned issues, and that link is https embrace.pitt.edu, and I'm going to reshare that link in the chat to bring it up to the top of everyone's comments because we've had a lot of things shared. And then Buffy Jameson, Faye also had a question mentioning, they said, you mentioned that empathy levels go down in healthcare students from the first year to their fourth. The amount of trauma that graduate level students face is enough that there are high suicide rates. Do you think that contributes to that?
Absolutely. Again, I'm not an expert in this data by any means, but when you look at it overall, you can see that the decrease in empathy is obviously also associated with how drastically your medical education experience changes between your first and second years to your third and fourth, right? And then with that comes, of course, this idea of burnout, mental health, like well-being not being prioritized. You're taking board exams, you're doing all of this work. So of course, high rates of, suicide and burnout that we're seeing right now across, the medical system in general is definitely a symptom of a system that's not prioritizing things like empathy and well-being, right? We're like oftentimes working a lot of our medical providers to the ground, and that's also fundamentally a problem. And we're seeing, and again, that reflects in the data here where we're talking about mistreatment, and sometimes it's, one of the quotes from the qualitative data was a provider said, I feel like I'm coming up short again and again, no matter what I do, right? You just feel so inadequate and insufficient in a system that is built in a very specific way. So there's a lot of confounding factors and variables that really overlap here. And I think, I mean, I'm a large proponent of us really like breaking that down and saying, okay, let's look at burnout and stress and all of these components as how it plays a role in how we provide care.
You make a lot of really good points there, and that's people who are doing their best in order to serve, the greater public and undergo so much stress to the point where it undermines their ability to support those they have set out their entire academic careers and professional careers to support. That's both upsetting but also insightful. And of course, public health is about identifying those issues in order to improve things moving forward. We also have a question about how do you think AI can help?
I think this is actually a really, really important and interesting question. It's actually something that I've been kind of wrestling with at the start of my PhD program is, talking to my advisor and saying, okay, we're building solutions for a healthcare system that is fragmented, that doesn't work. And it would be foolish to not consider the implications of AI and technology because the world that we live in today is going to look drastically different 2 years, 5 years, 10 years from now. It's looked so different in the last five where we've really seen AI come into play. So it would be objectively foolish to not consider how it can help. Now, at the same time, though, I do have reservations about how we implement and use AI and other, tools in that way. I think a big component is ensuring that, if we're building technology or building AI models and tools and, um, machine learning, methods into medical care, we're doing so in a way that does not further isolate a patient, right? We already have this interplay of provider, technology, and patient ongoing at present without AI being a problem or being involved. And so what does that mean in terms of, again, who is that expert in the room? Who is actually making those decisions at the end of the day? What can we do? And I think also a big thing with AI, algorithms, ML is that we also consider, are they being ethically built and designed to handle
Yeah.
a very diverse, patient population, right? I spent a lot of time in grad school looking at the vaginal birth after cesarean algorithm in the United States and how it was, naturally, artificially inflating risk for Black and Hispanic women strictly off of the race category. So all other variables of maternal risk could be the same, age, BMI, etc. But the minute you change that race, variable from white to Black to Hispanic, you had a significantly increased risk of an unsuccessful VBAC, right? And what does that lead to? More C-sections for a population that's already vulnerable, and then you have more complications. And then again, that cascade, right? It continues on. So if we're really integrating AI, we're really looking at, tools like this, I think it's really important to consider like how are we building and justifying that type of authority and what does that really mean in terms of actual clinical practice. And if you're interested in this at all, I would actually dive down the rabbit hole of epistemic authority as it applies to predictive technology in medicine. And there was a really fascinating article which I can find and link or send somehow about predictive technology in neuroscience specifically and what that looked like from an epistemic authority perspective of like who is the ultimate say in the room, right? And it should not necessarily be technology, but if we can use technology to make a decision more objective and less biased, that has some utility.
Mhm. Well, that's you've raised this session has been so incredible because so many different things have been raised. And thanks so much for that and that thoughtful reply. We're getting to toward the end of our session. I think we have time for one more question, and it's a very apropos one. Jerica Knox asked, "How can someone reach you?"
You can absolutely reach me by email or LinkedIn. I'm on, both platforms. I'll drop my email in the chat right now, which is my MGH email. I'll also, I'll even give you my personal one as well, so you have options to reach me. But I mean, I could talk about this for hours and hours and hours. So I will happily, I would love to reach out to any of you. Please reach out to me. If you have other questions, you'd like other resources or reading material that I've come across in my time working on this, I would love to share that. So yes, absolutely.
Oh, wonderful. Just making sure. Oh, we have one final question that I just saw here. It's from Jeffrey Cooper. I'm going to allow them to talk. Jeffrey, you're live if you would like to come off mute.
No, I just wanted to say thank you for stating that response so eloquently about the unbiased algorithmic bias that you discovered in the research. Thank you.
Thank you. I appreciate your appreciation, and I think it's a really important part of if we're ever going to implement more algorithms and clinical decision-making tools relying on technology, that we really take a look at the human that is coding that work and if what bias is being introduced and then codified in clinical care.
Oh, wonderful. Sahana, I want to thank you so much for being here today. And as Rita Wiltz just wrote in all caps, this was a great session indeed. And I'd like to hand it off to my colleague as well.
Yeah, no, thank you again, Sahana. We would definitely love to have you back. So if you have like encores to like your this talk, definitely, I think you have like quite a robust audience that came. And I know I was texting some people as well, who are on the YouTube channel. So thank you so much. Thank you to the audience. We look forward to seeing you guys at the next webinar in the next couple weeks.
Yes,
Thank
and
you.
look in your emails for your certificate of participation. And if you have any questions, just write to communications@bcph.org. Also, very quickly, wanted to share that we do have some upcoming webinars as well. Obviously, Sahana is one of our 40 under 40. You can learn about that at our website. This is an award that's available to all of our members. You can learn about that at bcph.org. We also have a session coming up on November 12th about our World Delegates program. And then on November 22nd for our editorial fellowship that's coming up, which is a 2-month fellowship if you're interested in academic and scholarly publishing. And then we have a research scholars program that supports new and emerging thought leaders who are interested in writing and working with someone directly in producing a manuscript for scholarly publication. So thank you again for being here. And if you have a moment, please fill out the survey that's going to be coming to you via email. So thank you and good day.
Thank you.
Thank you, Sahana. Enjoy your evening in Oxford.
Thank you. Thank you. I will. Have a good rest of your day, everyone. Thank you so much.
Thank you. Bye-bye.
Seeing people slowly head out.